All right, chapter 23, which is poisoning and overdose. In this chapter, we're going to look at really everything in it is really poisoning. The overdose is just generally of medication or a recreational substance. And it may or may not be intentional. So really everything in here is poisoning. In other arenas they would call this toxicology. So in this chapter we really are going to be dealing with a lot of a pediatric problem, largely a pediatric problem. The other major category of people that we deal with these issues with tend to be people with behavioral or psychiatric issues. There are a few other types of poisoning that we will cover in here. Some of them will be related to other chapters that we touch on, such as injected poisoning. Injected poisoning, you can certainly have this from animal bites and stings. So that technically is a poisoning, although we usually will cover that in say environmental emergencies when we may have a person or even an allergic reaction. So some of this stuff kind of leaks over into other arenas. So we obviously have our objectives on pages 545 and 546 in the text. There's a number of objectives for this chapter. The thing about the poisoning and overdose is really we look at a couple of different routes that poisoning and overdose occur through, and kind of look at it from that direction. But in reality, a lot of what we see happen to the patient, the toxidromes and the toxicological effects that we see are very similar regardless of the way that the poison gets into the body. There are a few minute differences in between the way we treat patients with different routes of poisoning and overdose, but for the most part the four types really are very similar to each other. There's a multimedia video on cocaine overdose. The core concepts that we will touch on in the chapter will be how to know if a patient's been poisoned, assessment and care for the patients of ingested, inhaled, absorbed, and injected poisonings, assessment and care for patients of alcohol and substance abuse. So to start on poisoning. A poison is any substance that can harm the body. The harm it can cause results into a medical emergency, and all things are poison, and nothing is without poison. Only the dose permits something not to be poisonous. And that's an old saying, but it's very, very true. Water itself can be a poison, and it doesn't have to mean that it's water with toxins in it. Enough water, you can get water intoxication, which we're usually talking about gallons upon gallons upon gallons of water per day to make it actually a poison. But what it does is it'll wash out the number of electrolytes in your system, and that will basically poison your body. To make water a toxin, there's kind of an old saying that 88 8-ounce glasses of water can be a toxin. And in reality, you look at that, that's about 5 gallons of water in a day's time, and that's probably about right on. So our most common poisons we deal with, medications. Medications are common poisons in the, like I mentioned, the behavioral arena and pediatric arena, because so many medications look like candy, but they're also occasionally a problem in the elderly population, or people who maybe are in some sort of have a mental impairment where they're not able to recall, oh yeah, I already took my drugs today, and maybe they took their medication 4 times in the morning because they kept forgetting that they actually took it. Some of these are the reason why we see these pill sorters these days. Petroleum products are fairly common, more so in the pediatric population. There are very few adults willing to ingest a petroleum product. just not good. Occasionally there's some accidental exposures to petroleum products, say from inhaled poisons or even absorbed poisons. Cosmetics can be common poisonings, although they're not commonly eaten. Pesticides obviously are big. We have a lot of different pesticides and even herbicides that are around our homes. Many of us may be dealing with some sort of a minor pest problem, whether you've got a flower garden you're trying to keep certain bugs out of, or maybe you live in a particular building that has problems with insects and whatnot, or even you're trying to keep the weeds out of your yard. And in those cases, you may have some common pesticides and herbicides around, and they can create some very, very, very bad effects. Plants can be poisons. There are a lot of plants that certain parts of the plants are poisonous while others are fine. For example, you will find the substance cyanide in most of the pits of the fleshy pit fruits. So like apricots and peaches and plums and whatnot, you often will find cyanide within the pits of those. The castor bean. The castor bean is the is the raw product where ricin comes from. Even some of our other plants that we may eat. If you remember rhubarb, the red parts of rhubarb are fine for you. The green parts of rhubarb are poisonous. Now, with that being said, again, it is dose dependent. Eating a little bit of a green leaf is probably not going to do much. You eat a whole leaf or so, you probably might get a little bit of stomach ache in most cases. But and then there are others. A lot of times red berries are poisonous. So, and then there are certain types of foods that could be poisons to us. Like I mentioned, some of those other parts of the plants, and if you're allergic to it, it's sort of kind of like a poisoning. So the effects of poison are to harm. They harm the body based on the nature of their poison, their concentration, their route of entry, the patient's age and health. They may cause some damage to the skin and the tissues from contact with them. They can cause suffocation or local systemic damages to different body systems. And a lot of it just really depends on the substance we're talking about. If we're talking about a poisoning from exposure to, say, anhydrous ammonia will readily steal water from anything it comes into contact with. Whereas we may be talking about something like cyanide, which will get in there and compete for the slots for oxygen. There are other types of poisons that will start to just break down flesh. It'll start to break down blood vessels. Some poisons will get in what we call the neurojunctions and go in there and block the effects of some of the neurotransmitters, epinephrine, dopamine, serotonin, a few of those. It will block some of those, keep them from doing what they're supposed to do. So knowing a little bit about the poisons may be important. Now, with that being said, there are so many substances out there that it's very difficult to know. So using resources like a Poison Control Center really are going to be some of our best bets because they have the resources available and they can look it up. We may have some little field guides and books and web resources that we can use, and that's helpful. And there are even some occasional substances that we'll deal with in a hazardous materials incident that we're worried about. And there's a book, the North American Emergency Response Guide, that's often called the Yellow or Orange Book, that should be found in each emergency vehicle that will help us kind of start down the trail of treating this patient. Understand that many poisons do not have an antidote, and if they don't have an antidote, sometimes we're very limited on what we can do. So the four major classifications of entry route for poisons: ingested, inhaled, absorbed, and injected. So ingested means that we ate it or drank it. Inhaled is we basically snorted it or sucked it into our lungs. Absorbed means it came through our skin or one of our mucous membranes, and injected means something pierced through the skin, like a needle or a thorn or something, stinger has pierced the skin and started and put poison into the body tissues. So ingested, children will usually accidentally eat or drink something, not realizing that it's toxic, whereas adults are either accidental, depending on the patient's overall mental condition, or can be deliberate for either, it could be deliberate that they took the substance for recreational purposes, but it may be accidental, and in many cases probably is accidental if they overdose on something. They probably didn't intend to cause permanent harm. They just intended to get some of the good effects out of it. So that can be a significant issue there. Adults sometimes will deliberately intend to take a massive amount with the thought of causing self-harm. The sad thing is most people don't take the right stuff or don't take the right amount of stuff to get the job done, and they end up doing some permanent damage to their body, but don't get what they intended to do done. So one of my favorite stories was transporting a girl one time who tried to kill herself by taking 8 ibuprofen. I'm like, silly girl, that's a headache for me. So sometimes they're just not, and it's probably for the best that they're just ignorant to what the toxic or the lethal dose is. So assessment of our ingested poisonings, we're going to look for what substances are involved. We're going to look for containers, we're going to check for labels, we're going to transport that with the patient to the hospital if it's safe. And in many cases, in ingested poisons, it is safe for us to take that with us. Just make sure you don't put it in your mouth. When did that exposure occur? There are some quick-acting poisons that require very fast treatment. For example, cyanide. This one's always been one that's kind of befuddled me. We have a lot of ambulances, paramedic level ambulances and ERs that carry cyanide poisoning kits. And in reality, most people who suffer a significant cyanide exposure are dead long before we even get there. So it's really kind of depends on the situation, depends on what they're exposed to. If they ingested something, in most cases, ingestion takes 10, 15, 20 minutes for us to start to see any effects, as opposed to something that maybe is inhaled or injected, which is almost immediate. So a lot of these poisons have to be dissolved in the stomach, then transferred into the bloodstream for them to start to have some sort of an effect. So we have to be aware of when this exposure potentially occurred or guesstimated, and then move along quickly. ER personnel need to know for appropriate testing and treatment. So if we have an idea, try to get the substances, try to get an accurate history of when it may have been taken. In reality, if a person has ingested something and it's been in their stomach for more than about an hour, they've probably absorbed a significant amount of it, and a lot of it has probably moved on to the gastrointestinal tract. So simply treating the stomach alone may not do a sufficient job trying to get some of this poison out of them. Try to guesstimate how much was ingested. So estimate the number of pills by looking at the prescription label. So if you can say, well, today is the 16th, and this was a whole month's supply of 30 pills, 60 pills, 90 pills, depending on how many times a day they take it, and they filled this prescription 2 days ago, and there's 3 pills left, and it's supposed to be for an entire month. That's a pretty good guesstimation that, wow, there's a significant number of these missing. Can we say for sure that they took all of those? No, we can't. Can we attempt to get some information from the patient? We can try asking them questions, and they may or may not be cooperative when we come down to right down to it, depending on their intent and purpose. So sometimes it's a crapshoot. Over how long of a period of time did they take this? Is this the very first time they've taken the medication? Do they take it all the time? Some of the purpose for this is people get sensitized or desensitized, actually, to certain types of medication. So somebody who maybe broke their leg gets put on maybe Tylenol with codeine, which is acetaminophen with codeine, or often called Tylenol 3, and they may be put on, say, 325 and 5, and over time they work their way up, so they're now at 525. So they're constantly looking, and maybe that's a bad example because it's actually 2 medications. If we think of something, maybe a person gets put on morphine, and maybe they take 2 milligrams of morphine on a regular basis, and over time it stops working as well for them, so they work their way up, and next thing you know, they're on 15 milligrams of morphine. So what most of us on 15 milligrams of morphine, that we don't take narcotics on a daily basis, 15 milligrams of morphine for many of us would put us on the floor. But there are people running around who 15 milligrams, not a big deal. So it's kind of important to know that as well. And the body has permanent effects or lasting effects from some of these medications as well. So what interventions have been taken? Have you tried anything at home? Some people will hear drink milk. Other people will try to make themselves vomit. Syrup of Ipecac. You can still buy syrup of Ipecac. You don't see it as commonly as you used to, but syrup of Ipecac is a medication that is intended to induce vomiting. We used to carry it fairly regularly in EMS. We understand that causing vomiting sometimes is more of a harm than it is a good. So they may have tried a few things. Are there any treatments that were indicated on the label of what they took? Because a lot of particularly cleaning chemicals and whatnot have suggestions for if this is ingested, what you should do. What is the patient's weight? The rate of onset of toxic effects is often related to the weight. What one person, a full-size 220-pound, 6-foot adult might take, and a 25-pound, 18-month-old, that's going to have very, very different effects on that person. It doesn't have to be perfect, but an estimated is good. What effects have the patient experienced? So ask them about things: nausea, vomiting, altered mental status, abdominal pain, diarrhea. Is there any chemical burns around their mouth? Any unusual breath odors? Do you see funny things like even paint? And when I talk about paint, spray paint, oftentimes you'll see that more in the inhaled poison. So look for these funny signs. Look for these potential clues. Food poisoning. Food poisoning can be caused by improperly handled or prepared food. In most cases, it's undercooked food. We hear about salmonella a lot. But symptoms can be nausea, vomiting, abdominal cramping, sometimes severe pain, diarrhea, and fever. The body recognizes that, hey, there's something wrong here. There's probably some bacteria. We need to get rid of that, so burn it off with a fever. This will normally occur within hours or days of ingestion. This is not something that you eat it and 20 minutes later you're dying. In most cases, we're talking several hours after ingestion. It takes a little while for those toxins from the bacteria to really start to populate your system. While they're still sitting in the stomach acid, in most cases you're really not getting any effect of that. So if somebody eats something and 10 minutes later is barfing their guts out in the corner, the chances are pretty good that unless it was just a giant glob of bacteria, not to be confused with cheese or yogurt, which really are kind of giant globs of bacteria, but unless it was completely bacteria, it's not going to occur that quickly. So treatments for food poisoning, you may or may not be using activated charcoal. In both Nebraska and Iowa, activated charcoal is not within the scope. So activated charcoal is going to be out. Just a real quick discussion on activated charcoal. Activated charcoal, and we've got some more discussion on this later in this chapter, but activated charcoal, or charcoal itself, is a good absorbent or adsorbent, and it helps to absorb different chemicals. Well, people sometimes hear about people putting charcoal briquettes into like their fridge, their refrigerator, because it helps remove those toxins and those odors. Anybody who's in the aquarium hobby know that we use activated charcoal in our aquarium filters to help pull the toxins out. Well, it's the same sort of thing. So this is just prepared in a way that a person can eat, essentially eat it, but it's really more like drinking it. Can ingest it and start to absorb any poisons that are in the system. And there may or may not be some antidotes. For food poisoning, we're probably not talking many antidotes. So like I mentioned, we have activated charcoal, which is an adsorbent, which means basically the same thing as absorbs. It is really not an antidote. It doesn't reverse the effects of the toxin. What it does is it absorbs the toxins and keeps it from getting into the person's bloodstream. So if it absorbs, you took a handful of pills and then chased it with some activated charcoal, in many cases a lot of that medication or drug would be absorbed by the activated charcoal. It binds to the activated charcoal, and that charcoal doesn't break down and go into your body system. It just continues to pass through. So eventually you pass it. All right, so we're going to kind of skip over these activated charcoal ones. That's a very accurate picture there. If you look at the straw, charcoal is black, and this is black. If you would happen to be on a service in which the paramedic might be using activated charcoal, you would want to help them out by shaking the crap out of that bottle of activated charcoal. That stuff will settle. It's best to store activated charcoal on its side, otherwise it settles into the bottom of the round container and it's very hard to mix back up. But by setting it on its side, it's a little easier to mix up. There's a little more surface area that it can be kind of squished around a little bit and shooken up. It is very thick. It tastes like crap, even though they put some flavoring in it. It still doesn't taste good. And it's probably a good idea to try to use a cup with a lid, and if you can, an opaque lid, opaque cup, and opaque straw. People are going to see this and they're going to be like, no way, I'm not drinking that. It's going to taste bad enough. So anything we can do for a mental advantage to get them to try to take this, the better. Otherwise, they're going to get a tube down their nose or down their mouth, and it's going to get put in that way at the hospital. But again, not generally an EMT drug. All right, so think about it. You own a home. Is it safe for a small child? If you're a parent, you've already had to go through this. But is it safe for a small child? Well, what if you have neighbors and whatnot come over? So if that's the case, you got to be thinking about it. So are there potential poisons within 3 feet of the floor or behind unlocked doors? So parents are good at this in most cases of getting child locks and moving things up, and quickly kids start to find ways around. But are there any household cleaners that look like juices and fruit drinks familiar to children? So if it's pretty color, kids are going to be interested in it. Even if it's blue like Windex, that's going to look good to kids. So is there anything that looks any chemicals that look like other drinks? There used to be, and I don't know if it still is, but High C, or one of the fruit drink companies, used to have, I think it was High C, something called Ecto Cooler, and this was big when Ghostbusters was a fairly recent movie. And they had Ecto Cooler for the ectoplasm and whatnot. It looked exactly like green antifreeze that we put in our cars. I don't know if they still make it. A lot of our antifreeze now is actually taken an orange color to it, which probably makes it look even more like something we should be drinking. So can flavored children's medications be mistaken for candy? Absolutely. I remember as a kid, this was before it was a big deal for children to have aspirin. They don't recommend children get aspirin anymore in most cases because of their risk of Rye syndrome. But the St. Joseph or Bayer's baby aspirin, 81 milligram baby aspirins, and you may have these on your ambulance, or you may take them on a daily basis, but they're usually fruit flavored. They tasted good. I thought they were awesome. A little chalky, but they were good. So, and what sense does a child typically use to identify things? They'll use sight. They're going to use their sense of sight because, oh, it looks good, I'm going to check it out. They may not rely as much on their sense of smell. Their sense of smell may not be fully refined yet. And then taste, of course, taste is involved with smell as well. So public education really has to be a big deal for EMS. So whether you're doing open houses in conjunction with EMS week, or maybe your department chooses to do just one open house during fire prevention, if you're a dual department, those could be good times in which we do some public education. Maybe you can have an opportunity to get into the schools or the preschools and talk with kids. Talk with parents about child-proofing homes. There's things like the Mr. Yuck campaign, in which there was a face that was kind of spitting out stuff. And there was a label you put on certain containers that kids shouldn't drink or eat. So to move on to inhaled poisons. There are a lot of common types of inhaled poisons. We have carbon monoxide, which will be huge as right now is the beginning of the winter, the later fall and cold weather. Carbon monoxide will become very big because people will have furnaces fired up that aren't as well tuned as they could be, put out a little extra waste product, and that waste product is carbon monoxide. Remember, carbon monoxide binds to the blood 200 times faster than oxygen does. Ammonia, and in most cases we're talking household cleanser ammonia as opposed to anhydrous. Now in the agricultural setting, of course, anhydrous is huge. There's a lot of anhydrous around, but a lot of people still use ammonia in their daily cleaning, so that's a problem. Chlorine and chlorine bleach, those are potential issues. There's a chlorine around swimming pools, but bleach itself is chlorine, has a chlorine component to it. Mixing ammonia and chlorine, or ammonia and bleach, causes a very, very noxious and very, very toxic gas. So mixing those two cleansers is a bad, bad deal. Agricultural chemicals and pesticides, carbon dioxide. Well, carbon dioxide, don't we make carbon dioxide? Yes, we do. We make carbon dioxide. We don't commonly have a lot of carbon dioxide around, but it does get used in a few things, such as that's what makes the bubbles in your sodas, in your carbonated beverages, is carbon dioxide. So basically it can start to compete with oxygen. Obviously, if the levels rise high enough in an environment, your body doesn't give off carbon dioxide like it needs to. So scene safety, approach the scene with caution. If you get called to a residence and it sounds like there's a whole bunch of people ill at that residence all at the same time, that should be a red flag. That should be a red flag saying, hey, there's potential for a whole lot of people to get sick here, including us. So we need to protect ourselves. So we may need to call for fire, get SCBAs on. If we're not trained or equipped to do it, get those additional resources. Most ambulances do not carry SCBAs and full turnout gear. So if you don't have that, you may need to be on the outside waiting, and fire needs to be bringing the patients out. So some signs or symptoms of inhaled poisoning. Number one there, difficulty breathing. But very close to that should also be altered mental status, headache, and or confusion. Those two things should be kind of hallmark there. If you got difficulty breathing and altered mental status, particularly with headaches or confusion, you should be really thinking. Chest pains may be involved because if you take the place of oxygen, the heart starts to starve. Coughing, hoarseness, seizures can potentially be signs or symptoms there. So occasionally we'll hear people with carbon monoxide poisoning. They say have very cherry red skin. That is true, but it's very true very late. So early on in the process, you may be thinking, oh, this is carbon monoxide poisoning. Oh, no, they don't have cherry red skin, can't be. That's false, because that cherry red skin comes very late in the process. So with inhaled poisonings, try to determine what the substance was involved. You may not know. You really may not know. Now, you may be, I talked a little earlier, mentioned having paint on their face. Well, one of the things that some people do is huff certain chemicals, and huffing is inhaling certain chemicals to try to get a little high or an intoxication out of it. Particularly spray paint. There's a lot of spray paint that gets used. The huffer will often, they'll go to their local retail store, buy a can of spray paint, and just FYI, they like the metallic colors, so metallic gold, metallic silvers. That has the best high, apparently, in that setting. But they'll get the spray paint and the plastic bag that the checker puts it in, and then they take it out and they start spraying that paint into the plastic bag, which contains most of the actual pigment, and it also helps control where that intoxicant is, or the propellant. So then they'll spray it in there, they'll hold the bag closed, and then put it up to their face and suck out of there as much of the inhalant, or as much of the propellant as possible, and then the pigment in most cases stays there on the bag. But so you may have paint all over this patient. When did the exposure occur? Over how long did the exposure occur? Sometimes these are real crapshoots, particularly here with the furnaces firing up. We may have fired the furnace up yesterday afternoon, and now today we're all starting to feel a little ill. So how long has it actually been going? What interventions has anyone taken? The best intervention for inhaled poisoning is get them into fresh air. Remove the patient, ventilate the patient, and then what effects is the patient experiencing? A lot of that also depends on what they've inhaled. So getting the patient out into an environment where they're not constantly being re-exposed is paramount. Remember, if you are in that environment, you too are going to become a patient. So move the patient from the unsafe environment using trained and equipped personnel. Do not go rushing in thinking that you're going to save the world. All you're going to do is become a patient. Open their airway, provide them with high flow oxygen, and ventilate as necessary. Occasionally we have patients who are not able to maintain their own airway and or their own respiratory drive. So definitely high flow oxygen, and this is one case in which almost always high flow oxygen is good. Hyperventilating, probably not, but high flow is going to be good. History, physical exam, and vital signs, of course. Transport with any containers, bottles, and labels that are safe to do so. If you're taking something along that's still giving off vapors and fumes, you are not doing your patient any good, and you're putting yourself at risk. So you may need to contain it within another container of some sort. But don't put it in the patient compartment along with you and their patient if you are not able to control the fumes and it's not well ventilated, and you're constant ongoing. CO poisoning, carbon monoxide. CO is the appropriate abbreviation for that, not CO2. CO2 is carbon dioxide. So carbon monoxide is colorless, odorless, and tasteless gas. It's created by combustion. So if you have a fire, if you have a car running, if you have a furnace going, that all creates CO. It can be caused by improper venting of fireplaces, portable heaters, and generators. So something's not functioning as efficiently as it could. There's been a problem over the summer, and a ventilation shaft has gotten blocked and doesn't allow it to exhaust out. Those can all be big reasons for that to occur. Common cause of death during the winter and during power outages. People are trying to keep warm and don't even realize that they're being overtaken by these effects. They maybe went to sleep and never woke up, and it really didn't take them except in their sleep. So common signs or symptoms: headache, a band around the head is what they'll describe that as, or their head in a vice; dizziness and nausea; breathing difficulties; cyanosis. Again, they may have very bright red cherry skin, but that's going to be late. And they may be multiple patients with similar symptoms in a confined area together. That should be your biggest red flag right there. Because if we go to somebody who has a headache, dizziness, nausea, difficulty breathing, and cyanosis, that in and of itself doesn't usually lead us down the CO path unless we have some other accurate history that makes us go that direction. But multiple patients, same signs or symptoms in the same area, boom, that should say right here, CO or other type of poisoning. So CO monitors, there are a couple of different monitors you can use in conjunction with CO. Some fire and EMS systems have monitoring devices that will allow you to carry it on in with you and detect the level of carbon monoxide within that house, building, residence, or business, or what have you. So that's one way of monitoring. Often houses will also have carbon monoxide detectors in there. The other side of CO monitoring is when we talk about using some sort of a device to detect CO in our patient's blood. So there are certain types of pulse oximeters. The brand name of this is the RAD57 that does both pulse oximetry and carbon monoxide or methemoglobin monitoring. And with that, it will, when set up appropriately, and this is usually acceptable for any level provider to use this to help determine whether this is CO poisoning in most cases. But you can use this device that says, oh yes, there is a significant level of CO in this person's blood, and it helps guide you down that path. High flow oxygen is appropriate treatment, but CO bonds to the red blood cells much more strongly than oxygen, and it can take days to wash that CO from their bloodstream. A lot of patients with severe carbon monoxide poisoning will end up going to something called a hyperbaric chamber. A hyperbaric chamber is something that puts the body under pressure. It changes the size of the dissolved bubbles within a person's body and allows them to be removed from the body a little easier. It's like essentially diving down very deeply and then coming up. It's the same concept with the pressure. The normal use for, or the more common use for hyperbaric chambers originally was for divers who came up too fast and ended up with the bends or other diving problems. Well, CO can be treated the same way to help remove that a little quicker from the body. Smoke inhalation. Smoke inhalation from burning materials can be obviously poisonous. There's CO in it at least, sometimes ammonia, chlorine, cyanide. They say if you burn your couch, there's well over 200 different toxic chemicals that arise up out of this couch from the different parts of it that are burning. So smoke inhalation can be a real bad deal. These substances can irritate all parts of the body. Obviously the big one that we tend to look at is it affects the respiratory system and can lead to a respiratory and or cardiac arrest. So some additional signs or symptoms for smoke inhalation, really not different when we come to difficulty in breathing and coughing, but it's the next three that kind of tip us off. Smoky or chemical smell on the breath. Now that chemical smell could also be from some sort of a huffing incident. Black carbon sputum in their mouth, nose, or sputum. That's usually referred to as carbonaceous sputum. So they have kind of that black residue. Singed nasal or facial hair. I actually just took a burn patient the other day to a burn center who had something flash up in their face and burned off their eyebrows, their eyelashes, and their hair around their hairline. So fairly common. So smoke inhalation treatment, obviously remove them from the area. High flow O2, consider ventilating them. They may need assistance. And then monitor their airway very closely because airway burns can lead to swelling. So if they inhaled some smoke, was the smoke at room temperature? Well, in most cases, smoke is not room temperature because of the fact that there has to come from a burning source or a fire. So if we're talking about a patient who has been in a fire, we're probably talking about a couple hundred degrees gases coming out of that fire. So with 200, 300, 400, 700, 1,000 degree vapors, they probably not only got a toxic inhalation but also got an airway burn, and that airway burn is going to swell. With that swelling comes airway obstructions. Detergent suicides. It's a method of suicide started in Japan. It's becoming a little bit more common in the U.S. They mix two easily obtained chemicals to release a hydrogen sulfide gas, and is commonly released inside a enclosed area or space such as a car. So if you're called to a man down in a vehicle, a man down on the side of the road, something like that, and you approach this car, all the windows are up, the doors are probably locked, stop for a moment before you go busting into that car and look very closely. Is there anything that looks like an open container that somebody maybe would have mixed some chemicals in and created this toxic gas, this hydrogen sulfide gas? There are some other cases in which you have people that are doing something similar, yet they're also adding some sort of an explosive or incendiary device to the whole situation. So scene safety on something like this would be extremely critical. All right, so exposure to these fumes can injure you as well, can potentially even kill you. Warning notes may be left on the vehicle, but that's not always the case. So if you have one of these situations, be very, very observant, and you may need to treat the area as a hazmat scene. There may not be always something we can do for this person. They may be already gone. So absorbed poisons. These can be absorbed through the skin. They may or may not cause damage to the skin themselves, and the patient may require decon prior to treatment. Sometimes the poison actually doesn't do anything to the skin, but as readily absorbed as it is, it gets pulled quickly into the bloodstream, and obviously certain areas of your body are much more ready to absorb something. Say, for example, anywhere where you grow hair has a significant blood supply to it. So if that's exposed to a certain chemical, it's very easy for the bloodstream to pick up some of those poisons and toxins, as opposed to something, say, like the palms of your hands or the soles of your feet, which have a nice thick callus. They're not as readily able to absorb something. So assess for immediate life threats. Do a history, physical exam, and vital signs. Brush off any powder, then irrigate. You got to be very careful with that because of the fact that you can start to make some of this powder floating in the air, and then it becomes something that you can be affected by. There are occasionally dry chemicals that react very violently with water, say like sodium. Pure sodium metals do not deal well with water, so they can actually cause things to burst into flame. There are several other chemicals that will do this as well, but water plus a certain chemical means fire, oddly enough. Irrigate skin and eyes for at least 20 minutes prior to and during transport. I shouldn't say prior to, 20 minutes both on scene and then during transport. You need to flush that. The eyes are so critical that we make sure we get them flushed. You don't need to dump 5-gallon buckets of water on this person's face to irrigate their eyes. You need to have a steady stream go through their eyes. So yeah, we don't carry tons and tons of water on our vehicles, but we do generally carry enough that we can have a nice steady stream that washes and flushes the eyes out. Transport with the containers as appropriate. Again, if there's chemical spilled all over the side of the container, we may not want to take that just barehandedly into the hospital with us. We may want to contain that within something else. Poison Control Center. We talked about Poison Control Center is an excellent resource. It's an information for all our different poisons and signs. Just to keep in mind, the National Poison Control number is 1-800-222-1222. That's the National Poison Control number, and you can get a hold of them. You don't have to be a hospital to call the Poison Control Center. anybody can kind of get that ball rolling. You may want to have some sort of a system set up with your receiving facility, and that's a good resource, a good network to set up with your hospital, saying, okay, we'll get them called from the field, give them the information, they'll have it passed on to you guys hopefully by the time we get there. So have any information on what you suspect they've taken or been exposed to, signs, symptoms, and treatments that you've done, and then of course you need to follow local protocol. Alright, so we'll talk a little bit about alcohol and substance abuse. Alcohol and substance abuse is of course an enormous problem that we deal with. We see a lot of patients whose conditions are either caused directly or indirectly by alcohol or substance abuse. Remember that alcohol and substance abuse is very regularly part of the reason why we deal with certain vehicle accidents or traumatic injuries. So abuse of alcohol and other drugs across all geographic and economic boundaries. You know, usually the difference is what substances you're abusing. What can you get your hands on? Even hobos or the urban outdoorsmen or the homeless or whatever you want to refer to them can be substance abusers. Maybe that's all they spend any of their little hard-earned money or hard-begged money for is their substances. They've even learned some tricks that you can go buy a bottle of rubbing alcohol, which is 70% isopropanol alcohol, and you know, for 79 cents at the drugstore, you've got a whole night's worth of drinking there, and you'll be drunk very quickly. There are all kinds of things out there that people can get intoxicated on. It's just a matter of how badly you want it. So, and it's everywhere. It's men, it's women, it's kids, it's adults. It's you know, it's prescription drug users, it's illicit drug users. So alcohol abuse. Alcohol is obviously a very potent drug. It affects the central nervous system. Can be addictive, as evidenced by a number of alcoholics as we have in the world. Emergencies may result from recent consumption or years of abuse. In most cases, when we deal with an emergency related to alcohol, it's from fairly recent consumption. The long-term effects of alcohol leads to hepatitis, and cirrhosis, and so on and so forth. Even delirium tremens, where people are actually trying to quit alcohol, and now they're in withdrawals. Now that could be, that's really a kind of an emergent, or acute emergency, although it happened from years and years of chronic abuse. We're going to treat these patients as others. Sometimes we believe the person actually is drunk and come to find out that they have some sort of a medical condition, like they're having a stroke or they're diabetic. And abuse can lead to or worsen other medical conditions, obviously. I used to deal with a patient on a regular basis that would not take his medications because his physician told him, you cannot drink and take these medications. So he stopped taking his healthcare medications so he could continue to drink. Alcohol is often consumed with other drugs, which obviously can lead to serious medical emergencies. Impaired patients can be very uncooperative and combative. I've had a number of times in which I've had intoxicated patients that took a swing or two at me. And then law enforcement should be involved. Definitely law enforcement involved for everybody's protection. Many medical conditions mimic alcohol. I've mentioned this before. The stroke, the diabetic reaction, sometimes seizures. And then don't forget, intoxicated patients can also have medical problems. You could be having a good night drinking and out doing something stupid, and now all of a sudden you're having a heart attack. So you can't dismiss their medical issue. All patients should receive their full assessment, regardless if we think they're just a drunk. They all get the full assessment, and hopefully that helps us rule out any other major issues. So obviously signs and symptoms of alcohol abuse: alcohol odor on the breath, unsteady on their feet, or a unsteady gait, this is what's referred to, slurred or rambling speech, flushed and being complained of being warm. I think most people when they're drinking get hot, so you know, you see a lot of people who tend to remove clothing. Nausea and vomiting, poor coordination, blurred vision, confusion and altered mental status. I think most of us have been exposed to an intoxicated person before, but remember, many of these are just the same as we see in certain medical conditions. Alcohol withdrawals. This is the abrupt cessation of drinking. Can cause some alcoholics to suffer delirium tremens. Their body's gotten used to there being alcohol constantly available. It's kind of altered their chemical balances, and it can throw them into something called delirium tremens, often called DTs. And usually this ends up in tremors, hallucinations, and seizures are the most common signs that we see of DTs. Usually it's diagnosed via a history of chronic alcoholism followed by a quick stop in using alcohol, and then some of these conditions. They may also have confusion or restlessness. They may have some very unusual behavior. Their body is trying to readjust to not having that constant intoxication. Hallucinations. So of the care for the alcohol abuse patient, vomiting is extremely common. Anybody who's had a few too many can probably attest to that. Standard precautions are going to be essential. Have something for them to vomit in. Grab the trash can, or if you have little puke bags, whatever. Plan on it happening. Just plan on it happening and be surprised if it doesn't. Keep your suction ready to go. Be alert. Be very alert for airway changes. So if they are all of a sudden passing out, you may need to switch into resuscitation mode and maintain some airway. You may even need to ventilate. Obviously, vital signs. History is great, and pay attention for seizures. History may be, the history we get from the bystanders may be the only real history that we get on the whole situation, because the patient may not be reliable at all. So substance abuse, any other chemical, or any chemical really, taken for other than therapeutic reasons is substance abuse. So if you're taking a medication because it's helping you with a disease or a condition, that's one thing. Once you start using more and more and more of it, and it really becomes less about that condition and more about a good time, and that is substance abuse. This is anywhere from illicit drugs or street drugs, recreational drugs, prescription medications, industrial chemicals. People, kids are using that what they think is compressed air that you use to blow out the keyboards and other electronics to keep them cleaned up. They think it's canned air or compressed air. It's actually not air. It's actually a compressed chemical gas that they think is safe for them, and it is not. It's very, very dangerous. So all kinds of industrial chemicals and issues. So some general categories of substances that we may be dealing with. Uppers. Uppers are stimulants that affect the nervous system. Cocaine, amphetamines, caffeine are uppers. Cocaine and amphetamines usually are intended to keep you going, keep you up, keep you awake. Cocaine and amphetamines both are used medicinally. However, most people don't realize that there is a medical version of cocaine. Cocaine is used ironically to treat nosebleeds because it helps constrict blood vessels. It is a cane drug, and any cane drug is also an anesthetic drug, so it helps numb things up and constrict vessels. Amphetamines, anybody who has ADD has probably been on an amphetamine. Ritalin is an amphetamine, and it actually is attempts to increase your awareness and make you more susceptible to paying attention to what's going on. Downers, on the other hand, these are central nervous system depressants, such as barbiturates, rohypnol, or roofies, or GHB. So we've got the date rape drugs here. Barbiturates are actually a common medical drug that formerly was used a lot for seizure patients. So we've got lots of drugs that just kind of make you not care what's going on. It kind of gets you sleepy. It may be used to help you relax. Maybe people are taking it to help them sleep, but you go a little over the top, and sometimes they do a very good job of causing people to be a bit, to get a bit of amnesia and not realize what's going on. Narcotics, these are used to relieve pain or to help with sleep. In most cases, we're talking about opiates. Opiates are derived from the opium poppy, and narcotics specifically, the term narcotics gets abused to mean any illicit drug, but narcotics is specifically drugs that are intended for pain control. So heroin, codeine, morphine, Dilaudid, Tolwyn, fentanyl, Duragesic, oxycodone, there's tons and tons and tons of them. Acetaminophen with codeine, paregoric. So there's lots of potential drugs, Demerol, that could be in this category. The thing about downers and narcotics is they both typically will cause you to have respiratory depression. So these are patients that we very well possibly could need to ventilate. There is a hallmark sign of narcotic ingestion or narcotic overdose, and that is pinpoint pupils. That's provided they don't have any other eye injury or not on another medication that alters that. But in most cases, people that are under the influence of narcotics have very, very tiny, tiny black pupils. So pinpoint pupils. They also cause that respiratory depression and an altered mental status. So those are kind of that pinpoint pupils thing. That's only really for narcotics. Most of the other medication agents or drug classes, you don't get that. You may get dilation, but you really won't generally see constriction unless it is opiates. We have hallucinogens. Hallucinogens create an intense state of excitement or distortion. So most of these drugs are illegal. They have no medicinal use. That doesn't mean they never did. LSD and PCP both formerly had some medicinal uses to them, but they didn't last very long. So they change your perception. These are people who see things, hear things, feel things, smell things that really aren't quite the reality. Ecstasy also falls under this category. So, and in a sense, marijuana is also a hallucinogen / downer. So, volatile chemicals, these are anything that kind of create a rush. Back in the day, I remember as a kid thinking, "Ooh, boy, that airplane glue, that model glue, that smells pretty good." You know, maybe it was magic markers, maybe it was whiteout. I mean, there's all kinds of things that people very characteristically are like, they're like, "Ooh, that kind of smells interesting," or that smells. They may think it smells bad, but after a while, you're kind of like, "Yeah, that doesn't smell so bad." I never used or abused those, but certainly can recall thinking that they smelled kind of interesting. So their initial rush can act as a nervous system depressant, kind of makes them take away all their cares. So assessment of our substance abuse patients can be very difficult. The patient's level of consciousness in most cases is going to be pretty down, but there's a few, the uppers, for example, they may be very manic and running around. Remember, patients can take multiple types of drugs. There's sometimes that I think it's kind of popular with the kids these days, is doing skittling. Skittling is you bring a bottle of pills and then everybody dumps their bottle of pills into one bowl. They mix it around. You grab a handful of pills and pop all these different pills, and there's blue ones and red ones and green ones and whatever. You know, so who knows what sort of effects you're going to get from it. Be safe. Use law enforcement. Probably going to be uncooperative. And be aware of the possibility that there may be contaminated needles and chemicals and whatnot. Because they're not doing something that's real legal to begin with, there's the risk. There's a lot more risk towards you. So signs and symptoms of downers: sluggishness, poor coordination, decreases in pulse and respiration. Uppers, on the other hand, they're very excited or restless, and usually will have an increased pulse rate and respiratory rate, maybe hypertensive. Sweating is common in hyperthermia as well. Sometimes they don't sleep for days. Think about people on meth. They may go days and days and days without having any sleep. narcotics, they typically become very lethargic. They'll have the pinpoint pupils, cool skin, respiratory depression, and a coma. And hallucinogens, they typically are a little bit more on the upper side as far as their vital signs, where you have rapid pulse, you may have hypertension, you may have flushed face, but then they also are seeing or hearing things, maybe even feeling things, and they will have dilated pupils. But sometimes they also will be down. They'll be kind of near comatose. Volatile chemicals, we typically see the disorientation. They may have some swollen membranes or burns or paint or what have you around their mouth or nose. Maybe complaining of numbness or tingling. Maybe a headache, changes in heart rhythm. If people are inhaling stuff, they're displacing oxygen. When you displace oxygen, the heart doesn't work quite as well. And obviously the residues. So treatment of any of these substance abuses is really all supportive. So it's maintaining airways, ventilating patients, providing oxygen, treating for shock, suctioning as necessary, maybe an OPA or an NPA, and keep them calm and transport. Don't forget, call for ALS. When you're doing your physical exam, look for things like track marks. You can see that all up and down this person's veins up by their elbow there, or what's called the antecubital fossa, there are all those little bruises, and that's all where they've been sticking needles in there and injecting drugs. So those are track marks. Transport as soon as possible. Contact medical control. There's probably not a lot you're going to be able to do. So contacting medical control, getting ALS on the way can be a huge help here. And then local protocol concerning restraints. Do you need to restrain your patient? If you need to restrain a patient, usually you need to be talking with medical control and consulting with law enforcement. So the cocaine video that you can watch in the other version. So chapter review. Perform your primary assessment and immediately treat any life threat. So airway, breathing, circulation, suctioning. If you're not sure, you may even need to consider, did this person get hurt while they were doing whatever that they did? You may need to immobilize them. So you have to just be cautious. If the poison was inhaled or injected, high flow oxygen. History, physical exam, baseline vital signs. Try to gather as much information as you can. Cautiously, if you can, take containers along with you. Otherwise, take good notes of what you saw and what you found. And you may need to leave some fire guys behind to kind of do a little more snooping. But what interventions have been done? Try to find out what they did prior. Consult medical direction as directed. We're usually not going to give them activated charcoal, but poison control may indicate water or some milk. Activated charcoal, remember, not in your scope at this point. Remove the patient who has an inhaled poison from that environment. High flow O2. Brush off any residues of poisons that are on the skin. And remember to protect yourself. Transport your patient with all the containers like I mentioned. Reassess, and then document as much information as possible. Remember, safety is always a concern. Either the patient is going to be unsafe or the potential for the environment or the substance around to be unsafe. We generally classify these by the route of exposure. Route of exposure tells us a little bit about how quickly we can expect things to occur. A thorough assessment is going to give us the best clues. It's going to give us the best history that we can provide to the ERs so they can do the appropriate treatment. And poison control centers often have tons of resources they can help you with and start that patient down the road to potential recovery. Alcohol is a very, very, very common problem we deal with. It may lead to other problems, may lead to traumatic injury or other medications or even a medical emergency. The effects of substance abuse are going to vary greatly depending on what they use. So a couple questions for you to consider. What are the potential risks to the responder on a poisoning or overdose call? That would be exposure yourself and or violent patients. What are the routes of entry into the body? Injection, ingestion, inhalation, and absorption. And then what are some things that EMS can do to prevent poisoning, especially in children? That's a lot of outreach, open houses, going and talking to schools, talking to parents, babysitters, so on and so forth. So critical thinking. A farmer calls 911 because one of his farm hands has tried to clean up a spilled pesticide powder with his hands. On arrival, you find the patient that insists he has brushed all the powder off, he feels fine, and doesn't need to go to the hospital. As he talks, he continues to make brushing motions at his jeans, on which you can see the marks of a powdery residue. How do you manage the situation? Well, at the very least, we need to get him out of those clothes. Because if he's wiped the poison on his jeans, the jeans can absorb the poison and then in turn pass it on to the patient, and he can absorb it through his legs. So at the very least, he needs to get out of those jeans, and he needs to get showered and cleaned up to rinse off any remaining residues that are there. We should still recommend that he goes to the hospital to be checked out. We should take a note of any chemical labels and whatnot. We should recommend that he go in and be checked out, and if he'll allow us to take him in, great. And then just continue to monitor him. As long as he's not having lots of signs and symptoms right now, we're really more in a monitoring mode and supported mode than we are in a resuscitation mode.